Just give them the date. St. Patrick's. Okay. Okay. Okay, just as we're getting reorganized, welcome back, everybody. So I've been asked to just make note that we're having some technical difficulties uploading documents to our committee page. So just for the public, we're working on getting that fixed, so the documents that we have today and the slides and so on will be available on our committee page when we're able to resolve that difficulty. So there's that. And I think we've got most everybody back. I hope everybody had a nice little break. And it's actually not that common for us in the legislature to actually have lunch, take a break. We usually don't do that, right? It's like we all kind of almost expect just to, tough it out, so on. But I think this is a lot more humane. We should get used to doing it this way. So next on our agenda, we have Dr. Saye Nikpe also from the university, and she is going to talk about some issues about pharmacy. So welcome to the committee.
Chair Liebling, thank you so much for this invitation. I'm so delighted to see many familiar faces in this room, and I'm hoping that I get to meet those of you who I don't know. I love to talk about health policy, so please, if there's anything that doesn't make sense, if you're interested in data, please come and find me, and it's my absolute joy to partner with you to solve health policy mysteries. So the word of the day has been complicated, I think we would all agree. Unfortunately, I'm going to drag us further down a road by complicating things even further by talking about Medicaid managed care, or Medicaid pharmacy, and basically layering on managed care to Medicaid pharmacy procurement, and then also talking about interactions between Medicaid managed care pharmacy and a program called 340B, which is a drug discount program that likely most of you have not heard of before. So without further ado, I'll get started. I believe I have 45 minutes. Is that correct? Okay.
Do we not have a handout for this one?
So I was just going to address that. Representative Doe, thank you for bringing that up. So first of all, yes, it was planned for 45 minutes and then some time for discussion.
Wonderful.
So we won't hold you to the minute. But in terms of presentation, I think we had a glitch in getting that printed, so we don't actually have it on paper, but it has been sent out to everyone on the committee. So did that just come recently?
Okay.
Today, so it would be, I think, from Josh Sandy's email. And for the public, we will have that when we're able to get it uploaded on our page, but it's also should be on the screen for folks who are watching.
Okay, wonderful. Hopefully I didn't make the print too small. So let's get started. Pharmacy is a big ticket item in Medicaid, in the Medicaid world. When we think about Medicaid, we tend to think about parents, children, and they tend to be healthier groups. But even for a fairly healthy group, we still have a lot of Medicaid spend that's going towards pharmacy. So you can see on the left, in the US, about $60.8 billion of the total Medicaid spend, which is about $560 billion, went to pharmacy. And in Minnesota, if we zoom in on Minnesota, of the $12.7 billion that we spent, these are from, I believe, fiscal 2018, of the almost $13 billion we spent, almost $1 billion of that was spent on pharmacy. So pharmacy, about $1 out of $13 is going towards pharmacy in this state. The part of the reason that it's going to get really complex is that Medicaid pharmacy involves many different actors. We have manufacturers who are required as a part of getting their drugs prescribed to Medicaid patients to provide rebates to states, and I'll detail how those work. Pharmacies that are reimbursed both by the state and by MCOs. We have many different types of providers. In my talk today, I'm going to focus most heavily on hospitals. That's not to say that Medicaid pharmacy is not important for other types of providers, but when we're talking about, where most of the pharmacy spend occurs, it tends to be sort of sunk in hospitals and hospital-based providers. And then we have the managed care companies represented by this card here. Think of it as an insurance card. Finally, we have the state, who is, you all are sort of in charge of this program and trying to regulate it. And maybe last but not least, we have the patients who have, challenges in accessing care, and Medicaid is supposed to be here to help them afford care while also balancing state budgets. So I want you throughout this presentation, my husband, this was his suggestion to add the slide because he is a very smart person, and every time I talk to him about Medicaid pharmacy, his answer is, wait, what? I need an example. So I'd like you throughout this presentation to think of a woman named Nan, and she's a 48-year-old mother. She's on Medicaid, and she has atrial fibrillation, which is essentially an irregular heartbeat, and she takes an oral medication called Eliquis. I apologize if I'm mispronouncing that. I am not a pharmacist or a provider. But so she takes this drug called Eliquis, and the list price is approximately $500 per month. I will say before I get too far into things that I am going to take many liberties. I know that this is a complicated subject, so I'm going to summarize in many different ways. So if you notice, well, that's not actually the price for Eliquis, I'm so sorry. I've just tried to make things into round numbers and make many different clarifying assumptions so we can get to the core of what needs to be known about this topic. So how do these pharmacies benefit? How does the pharmacy benefit work for fee-for-service? Let's start there because that's sort of enough to think about. So in Minnesota, if Nan goes to her healthcare provider, who maybe is a hospital-based physician, he or she provides her or prescribes her Eliquis. She goes to her pharmacy to fill that prescription and take it to deal with her medical problem. That pharmacy has purchased that $500 drug for a discount. We're going to assume that the wholesale cost that the pharmacy buys that drug for is about $450, okay? So the pharmacy has that drug stocked, and Minnesota pays that pharmacy for dispensing the drug to Nan. And the rates in fee-for-service that pharmacy would be paid are statutorily determined. They depend on federal rules about what pharmacies should be dispensed, plus some discretion on the state behalf of the state. Today, we're going to assume that pharmacies do not make a margin, which may or may not be a reasonable assumption, but for simplification, that's what we're going to assume. We're going to assume that the state is going to pay this pharmacy $450 for Eliquis, plus a small dispensing fee for providing and handling the drug. What this means is that the state has purchased a drug, this $500 list price drug, Eliquis, for Nan, at a net cost of $100. They paid $450, but they benefited from something called a Medicaid rebate. And that's this arrow on the right from manufacturers to the state. As I mentioned, in order to have Medicaid drugs prescribed, or in order to have drugs prescribed in the Medicaid program, manufacturers have to agree to provide these rebates. In this case, it's $350. So what is a Medicaid drug rebate? The way this works, and I should back up and say this is a rebate program that has been around since 1991, and it is a little bit complicated to understand, so we're going to take the time to make sure you get it up front. So the way that a Medicaid drug rebate works is it's based off of something called the average manufacturer price, which is essentially, you can think of the average of most of the prices that manufacturers let out the door when they're selling drugs. And the rebate is essentially the lower of, or the larger of, 23% of that average manufacturer price, or the difference between the average manufacturer price and the best price. In this case, for this drug, I've made this up, Eliquis, for Eliquis, it looks that the average manufacturer price minus best price is larger, and so that it would be part of the rebate. And then there's also what's called an inflation rebate. So if drugs rise at a rate that is faster than inflation, so if the price rises at a rate that's faster than inflation based on its launch date, the state also gets to have a rebate based on that inflation. Today, that inflation rebate is about the same size as what you're seeing on the left, okay? So together, this is the Medicaid drug rebate. What studies have found, now the rebates are private, we may not see them unless you have some inside information, or you're a director of procurement for a Medicaid. But in general, what we think is that these rebates knock about 51% off of the list prices for drugs. So it's quite a big discount. It beats out Medicare Part D's attempts to get rebates through PBMs. That's about a 21% knock off the price. And it also beats out commercial, which tends to get about a 12% discount on drugs when PBMs go to negotiate prices. So this is a really big chunk of money for the state. And to sort of hit home on why the rebates are economically significant, you can see here what this means nationwide in terms of dollars. So rebates have been rising over time, partly because there's been inflation. A lot of drug prices have been rising quite steadily and faster than inflation. But what we can see is in 2017, which is the last figure from this chart, there was about $64 billion of spend nationwide on drugs. But once those rebates were factored in, the amount that the US government spent on Medicaid drugs knocked down to just under $30 billion. So it's a big deal. And when we bring it back home to Minnesota, these are numbers for 2020, fiscal 2020. If we think about spending in 2020, we had about $927 million of gross spend. And that, after rebates, that amount was knocked down by $763 million to just under $200 million. So hopefully what this bar chart on the right is convincing you is that the Medicaid drug rebate is a really big deal. Okay, so how does this Medicaid pharmacy benefit work if we are running Medicaid pharmacy through managed care? Well, it's going to start in a very similar manner. Nan is going to go to her provider and she's going to get a prescription and then she's going to fill it at a pharmacy. Now these arrows are dashed because one thing that we've heard about this morning is that managed care provides some degree of flexibility. There's more scope to make changes to some of the rules that are hard-coded into fee-for-service Medicaid. So Nan's Medicaid managed care provider might have a formulary that dictates what types of drugs can be prescribed to her. They might have a list of pharmacies that are more preferred than others, or potentially have a back of the, a program sort of in back of house that Nan can't see, where certain pharmacies are getting quality payments and others are not, right? So these are the things that we think of managed care being able to do. So what's happening, though, is that the state, instead of paying that pharmacy directly for that drug, the state is paying a capitated rate to the managed care providers, which includes somewhere in there what they would have paid for this drug were managed care not there. So you can imagine that part of that capitated rate is that $450 that they would have paid otherwise plus a fee. But here's the place where we run into our first snaggle with managed care. We don't actually know what the managed care companies are paying the pharmacy. And maybe that's all right, except one thing that I think has been noted in this state and other states that are kind of similar to Minnesota with a mix of sort of rural and urban pharmacies is that pharmacies tend to be struggling right now. So, it behooves us to have some sense of what pharmacies are actually being paid. So what does stay the same, though, is that we get the rebate, and this was not always the case, but thanks to the Affordable Care Act, Medicaid managed care companies were able to also take rebates through the state, obviously. Or let me rephrase that. Patients who were covered by Medicaid managed care could get rebates. So here, the Medicaid managed care company goes to its transaction log, collects all the transactions, and then submits that to the state. And the state is the one to submit to the manufacturers and return that $350 rebate for Nan's Eliquis. And what this means is that still, in managed care, the net cost to the state of providing Nan with her Eliquis is $100. So Administering a pharmacy benefit through Medicaid managed care is a popular option. You can see here on the left, this is a map from the Kaiser Family Foundation. We have 34 states that carve Medicaid managed care or carve pharmacy into their Medicaid managed care plans. Only 6 have explicitly carved it out. And there are some that do a hybrid model. And you can see why, at face value, this would be very attractive. So maybe the biggest advantage of managed care in general, from my perspective, is the predictability of expenditures. This is a state government. You have to balance your budget every year when things happen that change the demand for pharmaceuticals. You are on the hook, right, as legislators to make a budget that balances at the end of the day, even if, the Medicaid pharmacy budget explodes. So by putting it into Medicaid managed care's hands, you take that risk off of the state balance sheet. It also may provide some continuity for beneficiaries. So their medical plan is through a Medicaid managed care organization. Why not also make the pharmacy benefit part of it as well? There's also the idea that administrative support and flexibility of, doing some utilization review or making formularies or things of that nature might also be attractive. And then some have said that Medicaid managed care companies may help the state in negotiating larger rebates. Now, that's not something that I've seen written about in the peer-reviewed literature. It's more anecdotal, but that may be something that is also an advantage here. However, there are also cons. So I'm sure many of you have heard that Medicaid managed care is a black box. Here is, in a little bit of a corny fashion, a black box. With Medicaid managed care, pharmacy, we lose some transparency. And with that loss of transparency comes a loss of control. It's not as easy to figure out what those pharmacies are getting paid. It's not easy to figure out what providers are getting paid for drugs. And that comes with a cost because you don't know if your pharmacy program is running as efficiently as it could be. There also is an issue of what I would call leakage of state dollars. So every time the pharmaceutical supply chain is very complex and involves many actors. And every time you add another intermediary in administering a benefit, there is the possibility for some of those dollars to get sort of lost to administrative fees. And I think this is something that we've seen. I'm not going to talk about it today, but I do know that it is something that is really on the minds of a lot of pharmacies, is PBM spread pricing. So sometimes Medicaid managed care, or mostly Medicaid managed care companies, they don't actually handle the payment of the pharmacies themselves. They deputize that to pharmaceutical benefit managers, and those pharmaceutical benefit managers may not actually pass all of that reimbursement that the managed care company wanted them to give to the pharmacy. They may not pass it all the way on to the pharmacy. They may keep some of it. And that potentially could destabilize pharmacies. The thing that I really want to talk about, though, is one of the disadvantages that I'd really like to talk about is how Medicaid managed care interacts with the 340B program, and so more broadly, how Medicaid managed care interacts with another discount program for drugs. So the 340B program, if you have not heard of it, is a program that's been around for over 30 years. The idea behind it was to create a special drug purchasing program to lower the costs for safety net providers of providing drugs. To set the stage for this policy, the Medicaid drug rebate was introduced in 1991. And around that same time, we got the VA purchasing program, which has very, very deep discounts on drugs that get administered to veterans. And at that same time, there was one of Senator Kennedy's staffers was concerned that there's a type of safety net provider that was missing. We're helping Medicaid agencies, we're helping the VA, but what about safety net providers who care for many uninsured patients and they don't have people who are covered by VA and they don't have people who are covered by Medicaid? What do we do to help them with rising drug costs? And the answer was the 340B program. And the idea was, let's help core safety net providers which started with many of the providers that we know rely on federal dollars to stay open, your FQHCs, your TB clinics, your urban Indian clinics, Ryan White clinics. And so this program was really meant to address their needs. And as time went on, as they were trying to get this bill passed, public hospitals got added, and as sort of a deal to make the policy actually get implemented, nonprofit hospitals were added as well, nonprofit hospitals who served a high enough volume of Medicaid patients. But so basically what this program does is it says to manufacturers, much the same way that the Medicaid drug rebate does, it says, if you would like your drugs to be prescribed by Medicaid, then you must give a 340B discount to different providers that we designate as eligible for this discount. And the idea behind giving this discount is that it would help the participants in 340B stretch their scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. And I am reading a direct quote because this particular language is maybe the most important piece of the enabling legislation for 340B. So the idea here is that we are giving a discount in order to help out some safety net providers. Before I get into the details of what stretching scarce federal resources as far as possible means, what I'd like to do is abstract away from all of the, there's a lot of minutia about the way 340B discounts work. For today, I want you to think about them on the same scale as Medicaid drug rebates. They involve kind of the same concepts, the formulas are similar, they're not exactly the same at the end of the day, but we're going to assume they're basically the same. I also want to not talk about the federal federal grantee clinics, okay? That is a pretty small portion of the program in terms of scripts. What I'm going to focus my discussion on is really hospitals and hospital-based providers, because that is where more than 3/4 of the scripts that are coming through this program are coming through. Okay, with that said, I also would like to set up some framing as we discuss 340B. In your head, you should be thinking about 340B as competing directly with the Medicaid rebate. There is a provision called the duplicate discount provision, and it says manufacturers, you know, they sort of are being squeezed between state Medicaid agencies and 340B providers. That manufacturer only has to give out one price concession. It can either be a Medicaid drug rebate or it can be a 340B discount, but it may not be both, okay? So set this up in your mind as we have 340B discounts or Medicaid rebates, but not both. Okay, I've mentioned this already. So another set of framing, just to think about who is participating in this program in the state. We have about 55 unique federal grantees, which you can think of as, you know, FQHCs and many Ryan White providers. The prison system is an FQHC, is a 340B grantee. Public health departments, so that's who's in that top bar, and we're not talking about them today. But in these bottom two bars, we have put 2/3 conservatively, but it's really more like 75% of Minnesota hospitals participating in this program. Some of them are rural, actually most of them are rural, given the fact that this is a highly rural state. And then we also have a number of general acute care hospitals that qualify because they have high dish patient percentages, or several pediatric hospitals. Okay, so now into the details. So we can think about 340B doing two things that are highly related, but we're going to separate them out. The first is 340B lowers the cost to providing care for indigent patients. And here's how that works. So before 340B, if a safety net hospital wants to provide care to this patient who's not Nan, someone else, and he is uninsured, and he needs Eliquis, they would be paying $450 to the manufacturer, maybe a little bit less because they go through a group purchasing organization, and then they would dispense that drug through maybe an on-site pharmacy, and they would just be out $450. So operating revenue would fall by $450, or sorry, their cost would increase by $450. With 340B, the manufacturer has to give the 340B provider this special price concession. The manufacturer lets the hospital buy that drug for $100, Then the hospital, the 340B hospital, dispenses it, maybe at its on-site pharmacy, and now they're only out $100. So it lowers the losses on this uninsured patient. And I think that this is, we would all agree this is good. We want, providers to provide discounted and maybe even free drugs sometimes to patients who can't afford it. The place where 340B gets a little more complicated is the second way in which the second way that it works. So it also provides a subsidy to 340B providers from billing insured patients for discounted drugs. So on the bottom of this figure, that 340B hospital is buying the drug for $100 from the manufacturer, that 340B price. But then they're going and they're billing this insured patient. Now this guy has insurance and he still is getting his Eliquis. His insurance is going to pay $450 or something negotiated between the provider and the insurer. And, because there's cost sharing, $400 of that payment is going to come directly from the insurer, but $50 is going to come from this gentleman. And that $450 then gets, you net out the $100 from the $450 accepted from the insurer, and that becomes unrestricted revenue that can be used to fund care. If you are familiar at all with the 340B world, the term for that $450 minus $100 is called 340B savings, and it's quite large. We think it's quite large. We don't actually really have a good sense. And when I say we, I mean the health economist community, the researcher community, health policy buff community. We really don't know. But we do think that it's economically significant. And the reason we think it's economically significant is from some FOIA-ing that's done by some actors. So this is from a blog called Drug Channels, which does, in full disclosure, receive a lot of money from pharmaceutical manufacturers. However, this FOIA request, which is unadulterated, is quite interesting, I find. So what Drug Channels did is they put in a FOIA request to HRSA, and they asked HRSA to tell them the value, the dollar value of all of the discounted purchases. That's going to be this $100 line. So what is the value of all of those $100 payments for Eliquis, for other drugs? Show us the value of those purchases, and then show us how the dollar value varies across different types of participants in the 340B program. And what you can see at the bottom, I want to direct you once again to this, to the federal grantees, and this is really the last time I'll talk about them. They're really only accounting for about 14% of expenditures through the 340B program. So they tend to be quite small in this space. However, for the hospitals, the hospitals make up a quite large share of 340B spend, with most of that coming through disproportionate share hospitals. So these are hospitals that are nonprofit that see a high enough share of Medicaid patients in order to qualify for Medicare DSH payments. So it's almost 78% of the dollar value of the purchases are coming through that. So how does this get us to savings? Well, we can look at the total dollar value of the expenditures, which was about $53 billion, the discounted expenditures, and we can compare that to the list price. Remember, with Eliquis, we had $500 for Eliquis, list price, and then we had the $450 that the pharmacy bought it at, and then we had the rebated price of $100. So this $53 billion number, that's totaling up all those $100 purchases, the discounted purchases. $106 billion comes from totaling up all of those $500 sticker price for Eliquis and other drugs. So if we compare those two, what that implies is that 340B savings could, in theory, be as large as $52 billion a year. Now, is it that large? We don't know, because providers may be using some of these drugs on uninsured patients. They may be passing discounts to some patients. We just don't know. But this is the upper bound of how big this could possibly be in terms of 340B savings. And just to put that in perspective, which arguably it is a large number, upper bound, But to put it in perspective, the total amount that was allotted for Medicaid DISH in 2022 was $18 billion. So it's potentially a very large pot of money. But we actually don't know what it is. The best we can do are these sort of back of the envelope calculations because the 340B program, 340B program spending is not tracked anywhere. There's no reporting requirements. And even the agency that is tasked with monitoring 340B, HRSA, has no authority to really collect any data except for some minor auditing purposes. And so this is potentially a really big pie, a really big hidden subsidy that we don't know much about, but we think it might be quite large. Okay, so how do states handle this? Because everything that I've been saying so far about 340B, we talked about this patient, right, who's insured. Maybe he has commercial insurance, maybe he has Medicare. But what about Medicaid? So as I said before, duplicate discounts are not allowed. A manufacturer is not going to give out, nor do they have to give out, both a Medicaid rebate and a 340B discount. So what this means is that states have to decide if they want to let 340B providers take those discounts. And if they do let 340B providers take those discounts, they have to figure out how they can get the 340B provider to accept a reimbursement that's as close as possible to that $100 they paid for Eliquis, okay? So it's, the other thing that I did not really touch on at all is that, Medicaid agencies are doing a lot. If you're someone who works in a Medicaid agency, I'm sure no one is like, I'm bored, I have nothing to do. Handling 340B prescriptions in the Medicaid space is very sticky. There's a lot of monitoring that has to happen. You have to sort through claims to make sure that you've segregated all of the 340B claims from the Medicaid claims, because if you were to accidentally put a claim that was subject to a 340B discount on your state drug utilization data list, which is the list that you use to go and get your rebate, you could potentially delay rebates for the entire state. And that would be really bad because these rebates are very important, I would argue, for Medicaid agencies. So many states have actually had policies that allow at least some 340B providers to take discounts on Medicaid patients for some time. So back in 2011, this is the earliest I could find anything written about states' decisions regarding 340B. In 2011, there were 26 states that had some form of written policy that determined who could potentially use these 340B discounts and who could not. Now, remember, using 340B discounts means taking the Medicaid rebate away from the state. Okay, so a lot of these written policies had things in them that said, like, please give us something close. Please accept a reimbursement that's close to your 340B acquisition cost. In 2019, the number of states that allow 340B discounts to be taken has risen quite a bit. There's 48. And I will say that Minnesota had written policies to handle 340B discounts on Medicaid patients in 2011, and we still do today. So in 2017, the federal government actually created probably given that there was such interest by states to start letting some 340B providers take the discounts, the federal government reset its methodology for determining pharmacy reimbursements. If you remember from those early slides, when in our kind of basic fee-for-service model, the state was reimbursing that pharmacy $450 plus a dispensing fee. And that $450 plus a dispensing fee came from a formula that was determined in statute, okay? So there's a 2017, or effective 2017 policy that essentially redefined the criteria for reimbursing pharmacies in fee-for-service for 340B drugs to include the 340B discount. And this essentially said, in law, states don't have to have their own written policies anymore. Now, if a 340B provider would like to use a Medicaid discount or would like to use a 340B discount on a Medicaid patient, that's fine. But as long as they're in fee-for-service, we're going to pay them $100 because we know that to be your acquisition cost. Okay? And so under this new law, actually the state should be relatively indifferent, holding all else constant. So the state's price to pay for Nan's Eliquis is still $100. as it was, without doing the 340B discounts. So where things get sticky is this new policy in 2017 may have preempted states' existing written policies. I am not a lawyer, nor am I an expert in administrative policy. But what appears to have happened is at least in Minnesota, the administrative documents that determine who can take, whether 340B discounts can be taken and what should be paid, say that, in fee-for-service, you're supposed to pay that, the state can pay something close to the acquisition cost, but in Medicaid managed care, it's silent. And so what we believe may be happening, although there's no way to confirm it since Medicaid is a bit of a black box, is that the state is passing on something akin to that $450 wholesale price in the form of capitated rates to the Medicaid managed care companies. Maybe the Medicaid managed care companies are paying that $450 to the pharmacy. Maybe they're paying a negotiated rate, but the 340B provider is getting that 340B discount and is capturing that money, that $350 of potential savings. So it means that the 340B provider gets to hold on to that $350 of savings, now 340B savings, but the state no longer gets to neither gets to list the drug on its Medicaid drug rebate list, nor does it get to offer that pharmacy a lower reimbursement. This is a problem because now the state's cost for caring for Nan and giving her Eliquis, the cost of providing that drug has gone up to $450 from that $100. So you might wonder why this seems like a bad idea. There's many things to consider about, whether it makes sense for 340B providers to take discounts on Medicaid patients or not. But there are some complicating factors such that even if you wanted to change this policy as policymakers in this state, you might have some difficulties. One is just the structure of managed care. You don't know exactly how those capitated rates are set and how 340B how Medicaid managed care companies are thinking about 340B drug discounts in the way that they price out pharmacy in that bid. And one thing that may be complicating things is I believe, 2019 law that was passed in Minnesota that essentially says that no pharmacy benefit manager in the state may reimburse a 340B provider at a lower rate than a non-340B provider. Now, there may be some language in this law that carves out Medicaid from this provision, but it's likely that, managed care companies are fairly conservative and they may be just deciding not to vary reimbursement whatsoever. If any of you follow Medicare policy, there has just been an enormous showdown over $9 billion of lump sum payments that are about to go out to hospitals for a cut. Medicare tried to cut rates to 340B providers for drugs and leave them the same for non-340B providers. And after 5 years of lawsuits and an eventual Supreme Court case, those cuts were undone. And so as a Medicaid managed care company, you may be very wary of varying your reimbursements by 340B status. So this is why in many different states, even though they allow 340B providers to take discounts on Medicaid patients in fee-for-service, where the 2017 policy ensures that the state pays the 340B price, many states have decided not to allow 340B providers to take discounts through Medicaid managed care. So Minnesota is one that does, but you'll notice that several other states in the region don't. And actually, this figure is a little bit out of date because it comes from 2019. New York actually carved out its Medicaid pharmacy benefit, which essentially takes the discounts away from everyone, and Ohio has sort of done some similar things. So states are taking action in this area, and I think have realized that this is potentially an issue, and they may not have realized that they were giving up their rebates in this way. Okay, so I think that there are some key questions here The first being that maybe you as policymakers would like to think about. The first is, how big are these 340B savings actually when they're generated off of Medicaid patients? Is this actually, is this actually a problem? Do we think that lots of 340B providers are actually generating savings? And which providers generate the savings is also an important question. I'll say in just a moment why that's an important question. Another issue is, how does your state's procurement process reflect, Medicaid managed care procurement process, reflect the cost of drugs for 340B and non-340B providers? In other words, is a managed care company thinking about what the actual costs are of the hospitals that it is, reimbursing, and are they potentially building that lower cost into their bid that they submit to all of you? And that also relates to what they're actually paying to those hospitals. And then, that's what I just said in opposite order. What I want to congratulate all of you on doing, and you may not realize that you've done something very special here, you have actually gotten us a little bit closer to answering the first question, which is, how big are savings, 340B savings on Medicaid patients? The way you've gotten us closer is you have created this new covered entity report in your affordability bill last session. So you may not have known this, but your covered entity report, which essentially asks 340B providers who are called covered entities in the lingo of HRSA, it asks them to reveal information about how large the value of those acquisitions were. So tell us how many discounted acquisitions you made and the economic value of those discounted acquisitions, and also tell us how much you collected from insurers in order to generate those 340B savings. So the covered entity report that you all brought into this world has got many people like myself who do research on the hospital safety net, on 340B, very, very excited. And that's because there have been attempts in the past. In 2018, there were multiple senators and representatives who were trying to get 340B transparency legislation passed, and they were not able to. Representative Buxton from Indiana is a person who's been very involved in this area, as well as Senator Cassidy from Louisiana, and Lamar Alexander from my previous state of Tennessee. We're all really, really working hard to get transparency and could not do it. 4 other states also attempted to get transparency. There were 4 states that attempted this last session to get transparency policy. And you were really the only state that succeeded in doing a kind of, pretty hard-hitting transparency policy. And I think we're going to learn a lot about it. Maine is another state who's passed one, although through their comment process, many of the things that they were asking for were sort of struck from the final legislation. Okay. So in my last few minutes, I want to talk about why it matters who's generating 340B savings off of Medicaid. So a lot of my research has to do with the economics of the healthcare safety net and how the dollars that we spend, whether they're explicit dollars like DISH or they're implicit subsidies or a hidden subsidy like 340B, how well those dollars translate to helping indigent patients, to helping Nan who cannot afford care without Medicaid, or potentially an uninsured patient like Nan or an underinsured patient like Nan. So there are multiple peer-reviewed studies. I've not listed them on their slide because there's many of them, but I'm happy to provide anyone additional briefing information or give you those studies if you're interested. There are many peer-reviewed studies that directly try to investigate the question of when a 340B provider gets more 340B revenue or begins participating in 340B, do we see any commensurate change in the level of safety net engagement, which you can think of things like providing charity care, even uncompensated care, care that has to be written off, providing key types of high value, low profit service lines, substance abuse care, burn care, things like that, or even the features of hospital charity care policies. None of those indicators appear to move at all when 340B providers begin participating in the program. That is troubling. I will say that is a on average number because, hospitals are very heterogeneous. I don't remember who made the comment, but it's true. We have hospitals that have, really kind of payer mix that's really more skewed towards uninsured patients. And we have some hospitals that have payer mix that's really skewed towards commercial patients and Medicare. But 340B in its eligibility criteria does not distinguish between those two types of hospitals, and everyone gets to come to the table and get those discounts. So we don't see any budge on average in any of those safety net indicators when we look across many different hospitals in a way that's not sort of cherry picking this one or that one or doing anything to sort of adjust the numbers. What several studies do find, including some of my own work, is that this program may actually incentivize strategic behavior to maximize the value of the dollar value of the 340B savings. So what you see is after hospitals become eligible for 340B, they may be more likely to go out and acquire a practice that prescribes high-cost drugs and is in an area with many insured patients, because that is a way to maximize the 340B savings. And they are less likely to put a pharmacy or a clinic in an area that has uninsured patients or Medicaid patients. Well, not so much Medicaid patients, because we're talking about how Minnesota lets 340B providers take the discount, but sort of strategically avoiding uninsured patients, because more uninsured patients in the door means less 340B savings and more just that lowering your operating losses. So for someone like me who spent a decade studying this program, we want to know more. We've done many things to try to put together as much data as we can. And unfortunately, there's not a lot of transparency. Again, thank you so much for your covered entity report. It will provide really valuable information that the research community needs to study this program. Okay, so if you are to take away anything from what I've just told you over this last 45 minutes, I want you to understand, I think you do, that drug procurement is complicated. And also that the Medicaid rebate, oops, this sentence ended too early. The Medicaid drug rebate is large and economically important to states. And Medicaid managed care providers, do some benefit in pharmacy administration space, right? It's not all negative. There's taking unpredictable expenditures on pharmacy away from the state. That has some economic value for the state. Potentially the tools of managed care could be useful in pharmacy. But by doing this, we are basically losing our ability to assess what's going on under the hood and whether the value that we're getting for money is actually there when it comes to pharmacy. And I also want you to understand, if you take away anything from this talk, that there are interactions between Medicaid rebates and 340B. And when you think about it, it's really a question of who is going to get the savings. Is it going to be the state, or is it going to be the 340B providers? As a citizen, what I think is interesting or important to me is I think that there should be a conversation, given what we know about what this program seems to be doing on average among hospitals, about whether that's a good decision. Does it make sense to have dollars that would have gone to the state to care for Medicaid patients shifted to private entities who, some may be very safety net engaged, and that may be fine, but others may be have very little safety net engagement, and that may actually be a policy problem. So I will conclude with that and just say I'm happy to answer any questions. I'm happy to talk about data, and it's just been such a pleasure to speak with you, and I welcome your questions.
Well, thank you so much. And we do have some questions, but I'm going to kind of start because this is incredibly difficult to understand, I think, especially for those who might be really hearing about it for the first time, and you really drew the short straw in terms of all the complex things we're talking about today, this might be the most complex. So thank you very much for that. So I just want to say a couple things. One, you've been using the term savings. We had a discussion about that. I call it profits. I know that that might be not as PC a word, I don't know. I think maybe in the research community or in the legislation or wherever it's called savings. But it's helpful, I think, to think of it as profits. So just to, I would just want to give the bumper sticker version of my understanding and ask you, am I off base, okay? Because sometimes this is how my brain works. I need like the bumper sticker version, right? So the bottom line here is that through the MCOs, MA is paying full price for drugs that we could be buying at a very discounted rate. And that margin, that profit between the very low 340B price and what they're selling it to MCOs for, there is a profit there. And then these hospitals mainly are essentially keeping that profit. I want to really make it clear to members, the MA program is paying for it. If it came through the fee-for-service program, we would be getting a very low discounted price. That's what we would be paying for the drugs that our MA patients use. When it's through the MCOs, we are paying essentially full price. But the entity that is capturing that profit are some of our hospitals that are under this 340B program. So is that bumper sticker correct?
Chair Liebling, that's an expert way of putting it. So I'll start by addressing your first issue. I'm a health economist. I would describe this as profit, but I know that in the 340B community, that is not, people don't like to call it profit, and so 340B savings is the name of the game. You may also hear it as 340B revenue, but it is a revenue minus cost, which in economics we call a profit. The second issue that I'll say is when we talk about drugs, and this is one of the reasons that my husband throws up his hands whenever I talk about this stuff, there's no such thing as a price, right? There's many different price concepts. So I want to clarify, when I say full price, I don't necessarily mean that sticker price. I mean the price that a managed care provider would pay in the open market. So it's going to be a negotiated rate between the MCO and the hospital, much as it would be if it was a commercial MCO or a commercial managed care company and the hospital. And so that's what I mean by full price. Another way to think about that is usual and customary rates or negotiated rates. But yes, it's true. It is a rate that does not reflect the 340B discount.
Right. And then I do want to clarify too, because I have some people writing to me, like, why are you doing this? I'm not saying that this is a bad program or a bad thing. It's just that with all the years I've been in the legislature working on these issues, never knew this was happening until very recently. There are potentially millions and millions and millions of dollars flowing through our managed care organizations that we don't know how much it is. We don't really know what it's being used for. So not that these entities are misusing the money. I don't know what they're using it for. We only know what they tell us. We have no way to verify it, and we don't know right now how much it is. So I just want members to wrap your heads around this. I know it's a very complicated area, but that's kind of the bottom line for me as a policymaker. Not that it's bad, but this is the money that our taxpayers are spending. We're spending it on their behalf. We don't know how much it is, and we don't know where it's going for this extra money that we're spending. Okay, so that's kind of why this is rising to the top as an issue. So I'm going to go to other members now. I've got Fisher, Nadeau, and Quam. So Representative Fisher.
Thank you, Chair Liebling, and thank you so much for your presentation. it's a lot to digest. One of the areas I wanted to focus on a little bit more is you were saying toward the end that when taking a look at hospitals before starting 340B and after, you were seeing no difference in charity care, et cetera. Was it charity care in terms of total dollars or total numbers being served? And where I'm asking from is I'm thinking is, say, if everybody on charity care was getting a drug, say, at $300, and now it's being $100, does that mean they're counting it at the $300, or are they counting it at the $100? Because if they're counting at 100, they're serving 3 more people than they were before. If it's at the 300, that's not true charity care that's being written off. It's, to me, only 100, and they've pocketed 200 elsewhere. Can you give some clarity on that?
Yeah, Chair Liebling, Representative Fisher, that is an excellent question. And I think that hospital finance experts have really thought about this a lot, how to standardize charity care as much as possible. Thankfully, the measures that I have used and others have used are all at cost level, not at the charges level. And so to the best of our abilities, we're looking at the actual cost of drugs. That may not be sufficient. You know, none of these attempts with what I would call secondary data, these are data that are available to us, are perfect. What we really need in order to study this program and see what's actually going on is true transparency data where we can actually see the dollar value of discounted drugs. But yes, we're looking at costs.
Representative Fisher.
Thank you, Chair Liebling. So what are things that need to be changed to give better transparency out there? What do we need to do?
Chair Liebling and Representative Fisher. So you've made an excellent start with the covered entity report. If you're familiar with it, it asks 340B providers to give the top line number of the dollar value of the discounted acquisition prices, the top line number of dollars accepted for reimbursements from different types of payers. That goes quite a ways. There's also some information on specific NDC codes and how big the discounts were for specific drugs. But one thing that would be very nice to know is, you know, much the same way that Medicaid managed care has, some middlemen that are involved, and there are fees and there are spread pricing and all of these kinds of things that maybe make the dollars leak away from the program. 340B actually has quite a few middlemen type entities that are involved as well. There are third-party administrators that help 340B hospitals and also the grantees to some extent learn how to manage their programs. There's, you know, consultants that help with strategic, you know, how do I maximize the discounts, help with billing, keeping separate revenue streams for 340B and non-340B drugs. There's also, so I really glossed over this because it makes everything much more complicated. So I talked about pharmacies that were essentially in the same box as the 340B provider, an on-campus pharmacy. But what's happened in the last decade is that 340B has really expanded beyond the walls of the organization itself to what are called contract pharmacies. And these are pharmacies that we all probably go to in our communities, and they have short-term contracts to administer 340B drugs. There's also fees associated with that relationship. The pharmacy may take a cut of that, of the 340B savings that come in the door from patients filling their scripts. So I think there's an opportunity to look for these kind of side payments. And I think we really need to understand, we have actually, through a lot of the reporting that the state has asked for already, through IRS reporting, we actually do have pretty good numbers already of top line charity care, community benefit, these types of things. But what would be really helpful for sussing out exactly what 340B is doing is, you know, get those charity care figures by payer and also potentially get them for drugs and separated by whether they were for drugs or non-drug services. So I would say that would be a good start.
Okay,
Thank you.
thank you. Okay, Representative Nadeau and then Quam and then Elkins.
Thank you, Madam Chair. And thank you. It's been an interesting concept. And I appreciate the information. I think one of the things, and I don't know if you were here for this morning, is that we seem to Let me ask one question first, and then I'm gonna make, I've got another question, if that's all right. The state of Minnesota, through its programs, it gets about $635 million in rebates. Do you know where that money goes?
Chair Liebling, Representative
Medicare rebates.
Neto.
Yep.
Medicare rebates?
Medicaid rebates,
Medicaid
sorry,
rebates.
yep.
So I could not say where the money goes. My assumption is that it just goes into the operating budget, but that's a question you could ask DHS, because DHS is submitting the rebates to the request for rebates to the manufacturers and then accepting that rebate money, which it's my understanding that it just goes to funding the program to run.
Well, just to follow up on that, Madam Chair, I mean, you spent a little bit of time talking about transparency. You spent a lot of time talking about how there's a lack of transparency in MCOs and PBMs. I appreciate that, it's fine. I mean, if we can't get DHS to be transparent with you on $635 million in rebates that we know are coming in, do we really have I mean, what is the problem with that if we can't get transparency from DHS on this massive dollar amount?
Chair Liebling, Representative Neto. So we actually do know the top line rebate numbers. If it's true that the top line rebates just go back into general funds, we can see how they're spending it by just looking at what's in the Medicaid budget. I think the dollars are fungible, right? They come in, they just get circulated into general operations, which I think we should just be able to infer through the budget. I don't think I've ever tried to access data on DHS's functions.
Right.
But I think that we actually can get that transparency because we can see the top line rebate numbers, and we can also see how Medicaid dollars are spent.
Right, and I'm going to try to answer that, Dr. Nick Pay, and then I'm going to see if Mr. Berg agrees with me. Of course he does. I haven't even asked. Of course he does. No, he knows if he disagrees, he'll tell me. I know that. I know him pretty well. We have as much transparency as any other money that we don't spend. It goes to the bottom line of the budget. So as you know, the way our budget works, we don't have a place in our budget where money in the HHS budget that isn't spent gets accumulated to be respent. It just goes to the bottom line of the budget. So when we have a surplus, that surplus, it just gets moved forward, projected forward in the budget, just like any other money that we didn't spend. So is that more or less accurate, Mr. Berg?
I think you're on track here. When you got to the we're moving it forward part is where I lost you. My understanding is about the same as Dr. Nick Pay's, is that if you look at DHS, they can, and this data is out there, they have it of the total MA program table by category. And it breaks the whole expenditure for the program down by a category of service, pharmacy, everything, hospitals, IEPs, I don't know, 20 or 30 categories. The pharmacy rebates are taken as a negative. It's an offset to the total cost of the program. So it's not like it's going to the, it does go to the bottom line, but it doesn't go to the bottom line as this dollar is a pharmacy rebate. It's just, it saves us X $100 million over the total cost of the program, is the way I look at
Yeah,
it.
so it's like money we didn't spend, that's all, because it came back as a rebate. So I guess so there's technical ways to understand this, but I think the bottom line to your question, Representative Nadeau, is this isn't, there are many criticisms we might want to make of DHS. I'm not saying there are not. I don't think this is one of them. They're not, unless something very untoward is going on, which I don't think there's any evidence of that, they're not grabbing this money and using it for a yacht for the commissioner. So.
My question is are the rebates, I mean, in this thing, and I don't want to die on this hill, I don't really care all that much, honestly. But is that money, we've got some pretty strict, requirements in the federal law for spending on 340B, and is DHS under the same requirements? I mean, can they, if that money goes to the bottom line, whatever, if it's unspent or not, does it go to ensure that we're increasing access and decreasing the cost to serve the populations that our hospitals are actually serving? So no one has to answer that right now because it moves into my next question. And it's the thing that we've been missing today is that we have a population, the Medicaid population, that the reimbursement rates for that population are severely lower than the cost to provide that service. We can argue whether or not the cost is too high or too low, which is fine, but the 340B program has been a lifesaver for our critical access hospitals and those ambulatory clinics that they've invested billions of dollars in to try to reduce overall long-term costs. So is it fair, from a health economist standpoint, is it fair to basically present this data without that surrounding data on the overall costs? Because hospitals, just like our jails, they serve everybody that comes through the door. Regardless of their ability to pay, they serve every person that comes through the door. So is it fair to not include that in this discussion of 340B?
So Chair Liebling, Representative Nadeau, let me back up to something you said about there being strict requirements on how 340B dollars are used. There are no requirements on how 340B dollars may be used at all. Like there's not even one place where it's written down, this is what you do with 340B dollars. They become completely unrestricted revenue. The statute asks the hospitals to sort of promise to intend in a loose way to use it to enhance services reaching more eligible patients and providing more comprehensive services, which has largely been interpreted as engage with the safety net more. But because there is no explicit requirement that any hospital is supposed to use their 340B savings in that way, nor that they have to report it anywhere, from my perspective as an economist, it's optimal behavior of the hospital to not use it on safety net care, because the more safety net care you provide, the worse it is for your bottom line. And this is unrestricted revenue. You should minimize the amount of safety net care that you provide subject to being eligible for this program and prescribe as many drugs as you possibly can. Now that's a bit craven, and I doubt that that's how hospitals operate, but using my Economist 101 training, that is how, if you were to game this out, that's exactly what you would do with this program. And there's nothing wrong legally with that. That is absolutely within the confines of the statute. So I just wanted to correct that. There is no requirement on how you use these dollars. They can be used for anything. The second issue, you mentioned critical access hospitals, and I think that is an excellent point to bring up. So if you remember the slide that I showed about where most of these purchases are, who's making most of these purchases in terms of their dollar values, we're not really talking about the critical access hospitals. And really what we're talking about is academic medical centers, large general acute care hospitals. The rural hospitals haven't really made too much of a dent in this program. As an economist, what I would say is if you were to design a subsidy program to shore up the safety net, which by the way needs shoring up, the dollar value of the subsidies that we provide to care for patients who are uninsured and underinsured do not cover the cost nationally of caring for uninsured and underinsured patients. If you were to design a subsidy program, this is basically the worst subsidy program that you could design, because it requires that hospitals or whoever is participating prescribe more medicines, prescribe more expensive medicines, and prescribe them disproportionately to insured patients. Those are bad incentives. And what I would argue is that a much better way is to acknowledge that there is need for those critical access hospitals, for safety net hospitals, hospitals that are caring for many uninsured patients. But then we should think about a different kind of subsidy program. We should think about subsidizing those hospitals directly. I'll give a short anecdote about why this can be problematic. So I was contacted for a story about an FQHC in Chicago. And they had been doing a lot of care in the HIV/AIDS space, and they had done a lot of expansion of their services to their population. And then that drug went off patent, and it became a generic. And the 340B revenue disappeared. It became nothing. And they had to fire most of their staff. They had to quit the service line that they had expanded into this community in a place where they really knew that service line was needed. And it was really bad for their community. So this program is not a great way, I would argue, to subsidize safety net providers, who I really do think we should be subsidizing. There's a need there. Yeah.
And I don't think that was that wasn't my argument. But you're making the assumption that again, hospitals are using drugs, which DHS controls the formulary on anyway. I mean, so you're making the argument that that's the incentive for the subsidy, and I don't think that's the case at all. I mean, I think that they're prescribing drugs, and for those in the formula, they get rebates for those particular drugs. So I don't know if that argument for me works. If we're to redesign our healthcare system, great, sign me up, I'll be on the committee. But I don't think that's what we're talking about here.
Yeah, so Chair Liebling, Representative Nadeau, that is not what I meant to imply either. I'm just trying to say that, you know, inherent in this subsidy, the more you prescribe drugs to insured patients, the higher the subsidy goes. And that's just like a mathematical fact. And some hospitals may be using it for wonderful things. Some hospitals may not use it for any safety net care whatsoever. We have no way of knowing. And that, I think, is a public policy problem. I think that there needs to be transparency in this program, because if it is incentivizing hospitals to do wonderful things in their community, that's great. Then maybe there isn't a problem here, a policy problem. But if it isn't, then the federal government and the state governments need to figure out how to redirect this subsidy to the providers in which it will do the most good. Unfortunately, you're a little bit limited as state policymakers because this is a federal program, and federal attempts to try to bring transparency or any sort of reform to this program have really been stymied. And I will argue that one of the reasons that I love this, you know, thinking about this program is because it really is a bipartisan issue. So a lot of the transparency legislation has been led by Republicans in the House and the Senate. You know, you as state policymakers do have some levers you can pull, though. You can pull the lever to increase transparency, which you are doing, and I think that's fantastic. And you can also pull the lever to decide which providers should be able to use, you know, generate 340B savings in Medicaid, if any should be allowed to do it at all. And if they aren't allowed to do it, you can figure out a way to directly subsidize those hospitals without 340B as an intermediary.
Thank you, Madam Chair.
Okay, Representative Quam, then we've got Elkins, then we have New Brindley. Representative Quam.
Thank you, Madam Chair. And this last discussion to members and public, hospitals in the state of Minnesota have some financial issues. And everybody should be aware that some things that they do, especially federal or state programs, don't always reimburse up to the cost. We're hearing in one case of where there's an area where they are probably getting more than cost. And their total budgets, if we tweak this, know that their total income will decrease without, you know, basically we've got to look at the whole package if we address this. The other thing that was enlightening is if it's DHS and they get this extra money, we're assuming it's going to the bottom line of that. If it's another entity, we're assuming automatically it's profit, and it's not to cover something that the government fee or rate is below cost. I am shocked that we keep saying we don't know, but fee-for-service provides the raw data of what the better cost price is, so the state gets that data and information and ought to be able to be nice enough to provide that to the entities that would be calculating, so we would actually know within a reasonable range what that is. And the discussion with the chair about, it goes to the bottom line and it sits, just days ago, there was a audit report given in which money was spent above what the legislature approved for, and there were issues. So I say there is data, facts, and reports that indicate that we should be looking at where this extra money comes in and where does it go. And I'd love to have the testifier and others that might be here provide some good questions to formulate a audit so that we can better understand, because we need to get the money to cover the cost for these people. And one of the best ways to do it is find out where there's waste, fraud, or whatever it is, and also find out what's working and not. Because we fix this, are we gonna cause an unintended consequence to some of these hospitals that are barely holding on and being forced in earlier testimony to come together, and merge into other entities? So offline, if you can send some of that information, and I would hope the chair would be able to convince DHS to share some of their information, because they actually have some. And if they don't want to share, I'll work on the audit commission to actually have an audit to find out what is happening with that money and the details. Thank you, Madam Chair.
Well, Representative Quam, I mean, first of all, let me just say that we're not changing anything right now. We're just talking about the program, trying to understand it. And there's no bill before us today. So, I mean, some of you are, you're kind of off into steps 2 and 3. And this is about people trying to understand what this program is. And the bottom line, there is a real difference of within our state budget, which we pass a budget, we have a spreadsheet, as Mr. Berg was describing, even when we get federal financial participation, it's on our spreadsheet. So, we deal with that in a certain way, and of course, we know there can always be, there are a gazillion audits, and we always have to keep auditing, and that's a given. What we're talking about here is a program where we're not just speculating, there literally is no accountability, as Dr. Nick Pay has been talking about. The law doesn't give us the data of how much is flowing through our program. We, as a state, our taxpayers, state and federal, are paying higher price for care than we otherwise would be because it's flowing through the MCOs. And the bottom line, where no one is saying that these hospitals shouldn't have the money, that it's too much money, but the bottom line is we don't know. We don't know, because there is up until now, there was zero reporting on it. There's zero reporting on it nationwide, I understand. The feds don't get the data. Nobody knows. And it's a concern, it should be a concern to all of us as stewards of the state taxpayer funds, that money is going out the back door where we don't know how much it is and we don't know how it's being used. No one's saying it's being used for bad purposes, but as in our role as state legislators, this is something we ought to at least know what it is, so that if we want to make a change, this is one of the proposals that we had, was to hold entities, keep them whole to replace these funds if we were to change the MCO system or carve out the pharmacy program so that we could keep them whole. But when we said, well, how much would it be? There's no way to know. So that's the point. We might leave it exactly as it is, but we can't say we're doing our due diligence if we don't try to get the data to at least know what we're spending. So I will.
Madam Chair,
yeah.
To that,
Representative Quam.
my whole intent is that because I'm sure some of us will be writing up legislation to try and address this and that. My whole attempt is so that we see this is such a global, complex, interacting thing that we should talk before we see the first bill drop on the desk. And I thank you for this hearing that allows us for that preparatory work before we can see a bill. But thank you, Madam Chair.
Well, thank you, Representative Kwame. I mean, this is a very complex issue, and you all know, during the regular hearings, when we have a bill, it just would be no opportunity for members to really even begin to understand this program. I know even today, it's taken me, and I still don't understand it, honestly, but it's taken me a long time to even get where I am. And Dr. Nick Pace was studying it for 10 years, and I've heard her say the same thing, so there you go. Representative Elkins and then New Brindley.
Thank you, Madam Chair. So I don't know about an audit, but I rather suspect that Chad Hope from DHS, who manages the drug program, is probably going to be appearing at this table relatively soon. There are two aspects of this that I haven't heard discussed yet, and would look for a reaction from Dr. Nick Pay and also from DHS when they testify as well. So I know from my own fiscal note battles that in addition to the basic Medicaid rebate, that DHS is in a multi-state buying pact where they contracted with a PBM called Magellan to negotiate additional rebates on top of the basic Medicaid rebate. And as with any PBM contract, those rebates come with conditions related to placement on the formulary, just like any other PBM contract with the plan. And first of all, wondering if Dr. Nick Pay has any comments about that, or is aware of that. But if not, I would certainly hope that when DHS testifies in this topic that we hear about that part of it. The second part would be that if we assume that the MCOs, when they're making their own deals through their own PBMs with the manufacturers, are receiving rebates, and typically most of that rebate revenue isn't passed on in the form of lower prices to the patient. Most of it is passed on to the plans, which use most of it to buy down the premiums. So my question related to that would be, is that on the MCO side, in this context, how does that money get, what's the disposition of that money when the patient and the payer in this case is the state? Is that reflected in lower MCO bids, or does it just disappear into the ether?
Dr. Nick Pay?
Chair Liebling, Representative Elkins, excellent questions. I'll address your second one first because I don't know the answer. I think that rebate dollars, we don't know how it would potentially affect, if we can accept higher MCO bids, or if PBMs, the MCOs using their own PBMs, if that, how they're using that money, because they do have their own PBMs. But as I showed you, the discount that can be negotiated through a PBM is never going to be even close to the Medicaid rebate that's sort of statutorily defined, but it's probably non-negligible. So I think that's something that DHS could absolutely figure out with internal data. I think to understand how 340B is interacting with the Medicaid program, there's a lot of questions around procurement and what restrictions the state puts on the MCOs when they submit their bids, and how they factor in pharmacy or PBM rebates as well. I think it would behoove us all to understand a little bit more about that. The other thing, though, I will say that you had mentioned that states were using that Minnesota is in a multi-state agreement to achieve additional rebates through Magellan. The rebate numbers that I showed you today included those supplemental rebates. When you look at the size of the rebates, there's the national rebate that you get that's just part of the formula, and that is the vast majority of that rebate. But then there's additional kind of state negotiated rebates, which is what this would be. It's quite a bit smaller. And then there's an additional MCO rebate that's going to be potentially the additional PBM. So I'm happy to provide you with those numbers if you'd like to see them. I think there might be a way to see how those change over time.
Yeah, and Representative Elkins, so, and maybe Dr. Nickpay, you can tell me again if this is mistaken or something, or maybe DHS would have to do that later, but my understanding, you know, these profits are not the MCO's profits, they are the covered entities' profits, so the hospital's profits. So the MCO, while it may get a cut, so here's what we might call the leaky bucket, you know, there's this big profit that's made at the drugstore and then, or at the pharmacy, and then you get different entities are taking a cut of it. But eventually, this is going to the covered entity, which is your disproportionate share hospital. So I think it's more of a pass-through. So I think the answer to your question is probably that it really doesn't figure into the capitated rate very much because it's a pass-through. But again, Dr. Nickpay, is that kind of how you think of it?
Representative Liebling, Representative Elkins, yes, that is how I would think about it as well. I think that's correct.
Okay, Representative New Brindley.
Thank you, Madam Chair. And I think actually my question is for Mr. Berg, but who knows? I can't promise that. My question is, so we talked about the entity capturing the profit. And right now, when hospitals qualify to be in the 340B program, they are the, to use your words, to the entity capturing the profit, right?
Right, we call them a covered entity.
And right now, as you said, the hospitals are not required to share discounts with patients. And of course, that's because their charge is to use those dollars to stretch. And it's the hospital that receives the 340B discount. It's not individual prescriptions for patients. It's that they buy the pharmaceuticals, they have them on the shelf, they just get the discount as a hospital. So we do know that much regarding the hospitals. My question is, regarding the entities that capture the profit, we addressed the top line number that DHS captures through the rebates, and we talked about how that goes into the bucket. Does that go into the Medicaid bucket, or does that go into the DHS bucket?
Madam Chair, Representative New Brindley, it's the MA bucket. When I was describing a table of the total cost of the MA program, one of the categories of which is pharmacy rebates, which is a big negative number. And so that is an offset, to think of it in the reverse of that. If we weren't getting the rebates, the cost of our program would go up by the amount we're getting in the rebates. So it's contained within the MA program.
Yeah, Representative Brindley.
Thank you, Madam Chair, and thank you, Mr. Berg. That's helpful. I wanted to understand that. So then it seems like, and Ms. Nickpay, to your point, this isn't a great way to subsidize providers. That may be true, and I understand, Madam Chair, that we're not hearing a bill today, but we did certainly hear bills last session that would affect this. And so it seems like if the argument is that this is not a good way to subsidize these providers, it seems very dangerous to just be in a position where we are proposing legislation to just remove that and capture those rebates for the state instead, without also, to Representative Quam's point, looking at how then, what is the appropriate way to subsidize providers? And it sounds like that's not necessarily just a federal question. We have some discretion there, but it seems very clear. I mean, even Mr. Baumgarten indicated that while hospitals aren't losing as much this year as they did the last couple of years, they are still losing. I mean, that's what Mr. Baumgarten testified to. And so to just remove that seems problematic. It seems that that discussion shouldn't be had in a vacuum. And so I hope that as we move forward with this into session, if we are continuing the conversation about 340B, that we're talking about that in a way that acknowledges it might not be the best way to subsidize providers, but we probably need to talk about what that is, whether that means if we're going to remove 340B, are we going to increase reimbursement rates? How are we going to keep these critical access hospitals solvent if we think the best thing to do is to remove 340B? Thank you, Madam
So
Chair.
thank you, Representative Brindley. So I'm right with you there. We did try, we found out, I never knew about 340B. I have long wanted to change the MCO system because everybody who knows me knows that I don't think we should be doing our MA that way. But, I only learned about the 340B program when we had a bill to carve out the pharmacy program. Couldn't do it because we suddenly found out that we were subsidizing them and didn't know it. So the point is, we did pass some legislation on reporting. We probably need to tweak that just to make sure we're getting what we need to get and make sure it can be as least burdensome as possible for the entities to report. And there is work being done on that. But no, I agree with you. We should not take it away if we don't know what it is, right? So the first step for us as policymakers is to learn what it is. How much is it? Where is it going? What is it being used for? And then we can think about, do we need to tweak it? Are there changes we need to make? But understanding what we're doing. So I'm totally there with you. I'm very glad you're thinking about it that way. That is exactly what we need to do. Find out what we're doing before we do it. Dr. Nickpay.
Representative Liebring, Representative New Brindley, I think that's an excellent point. And I believe the legislation around the transparency report talks about, collecting data, which I believe will happen in April. And then you all will get to decide how those data are displayed or analyzed essentially in a report, maybe to the public, maybe just to this committee. But I think an excellent thing to do would be to stratify your analyses based on, critical access hospital status, based on different, areas of the state of importance, rural areas. You could look at measures of medical underservice. You could look at, income, differences in income levels, differences in, all kinds of needs. But I would also encourage you to look at the distribution of 340B savings by different characteristics of hospitals and their extent of safety net engagement. And just, having that information will inform, I think, whether you do anything and if you do something, what you do.
Thank you. Representative Brindley.
Thank you, Madam Chair, and thank you for that. I would just say, I think we should probably be a little bit careful about our language when we talk about how we are subsidizing. Quite literally, the feds are subsidizing, and it seems that it is happening exactly as they intended to go to these hospitals and to spread that across those hospitals. And so I think we need to be very cautious about how we talk about that and how we do that, because frankly, we're not directly subsidizing. It means that we are getting less of the pie, right? That we are not getting as much as we might otherwise get under the rebates because it's going to 340B instead of the rebates. But that's kind of the way the feds intended it, and they did indeed intend it to go to these hospitals to make those offsets, because those hospitals, it doesn't say specifically that it's supposed to offset the cost of prescription drugs. It's supposed to offset the cost to the hospitals. So
Representative Brindley, maybe not the entire 340B program, but the state is subsidizing the providers through this program. And that's where my interest in it comes in as a policymaker. It is a federal program. We're not going to reform the program. It may need it, but we're not going to do that here. But the piece that impacts this committee and why I think it's so important for us to understand this I never knew about in all my years here. I never knew about it until very, very recently. And I'm only now really learning this very complicated thing. But the bottom line is, through the MCOs, we are paying that full cost. So it's not that we're not getting the discount. We are literally paying full price for something that we would not have to pay full price for because it's flowing through the MCOs and as a pass-through to these covered entities. And as the discussion went with Representative Nadeau, that may or may not be a good thing that they're getting that money. I'm not commenting on that. I'm just saying, literally, the funding that we pay, our capitated rates, are including some portion that is paying, they are paying the full rate. They're not paying it out of some other money. They're paying it out of Medicaid funds, of which we pay half and the feds pay half. So yes, literally, the state dollars are going this way. Another point I want to make is when the hospitals come to us and they say, we're in desperate straits, your rates are too low, they never tell us that they're also getting other millions of dollars through our Medicaid program. And, you know, it gives me, that's where we on this committee have to really scrutinize what we're being asked for. Now, again, I'm not doubting that you know, some hospitals are in difficult condition. There are a number of reasons for that. And we do need to be concerned about that, for sure. But I just want us to be cognizant that there's this money flowing through our budgets that we have not been aware of. So it is us. Otherwise, if it wasn't something that this committee is directly impacted by, we would not be having this hearing today. So just wanted to make that really clear. And Representative Bonner, final word on this final question, and then we'll go on to our final presentation.
I guess this is more of a comment than a question. You know, I just wanted to kind of do a quick summary here. You know, we talked a lot today about how this is costing us money. We've talked about the lack of transparency. There's no data. There is no reporting at all on this. And frankly, we've even heard some acknowledgement around this table and on both sides of this aisle that this is kind of a lousy way to do it. Let's be honest and transparent in that. But I think because and yet in some ways I almost hear us justifying this and continuing a lousy idea with no accountability. And this is what frustrates taxpayers. This is what frustrates the people that we represent at home. I mean, let's be honest about that. And maybe this is the right way to do it. Maybe it's not. We're having that conversation. But I think we can all acknowledge that it's kind of lousy, that there is no transparency. And the more important part about that is in all of this, we keep talking about it, and granted, we are the keepers of the purse, right? That's our job as the budget folks. But what we've hinted at it here and there all day today, but we haven't really talked about it fundamentally, is that the people who ultimately are paying the bill, our citizens, are the ones that are losing at every sense of this equation, at every turn. When we take those rebates and we're not passing that savings on to the consumer, to our taxpayer, they're losing money, right? That they're not getting that money back. We're taking that in a rebate. The patient loses. The consumer loses. When we talk about the difference in the rebates and who's getting what, the taxpayer loses.
But you don't give it back.
They're paying the bill, but they're not getting the benefit of better health care or reduced cost. And so I think it's frustrating, I think, for them, for us, and we really have to be having a better conversation about how the system overall is serving the people that we represent, actual Minnesotans. And I think that should be the center of how we create a better system here, and not about who's getting the rebates. And by the way, it's important to note when we talk about this rebate system that because of things like formularies and the rebate programs that we have, in some cases, we are actually driving patients and paying for more expensive drugs so that we can get a rebate than actually using a drug that costs less money, that does the same thing, which drives up overall healthcare costs, which drives up premium costs, which drives up the cost at the pharmacy. And once again, the taxpayer loses. And so I just hope that when we talk about this going forward, and whatever the solution may be, that at the center of this conversation isn't just about the dollars, but it's about the people behind the dollars, the people who need the care, and how we do that more effectively and efficiently and make sure that they get the care that they really need. Thanks.
Thank you, Representative Bonner. That's a great note to end on. Thank you very much, Dr. Nick Pay. Really great. Really appreciate your help here.
It's my pleasure. Thank you.
Okay, and so we will move on then to our final presentation from Catherine Costanza from NCSL.
Yeah, they're not gonna give the money back to taxpayers.
Thank you, Madam Chair and members of the committee for having me here today. I have a little bit of a cold, so I may slip in a cough drop at some point in time, so that's, if I start coughing or anything, I apologize. So my name is Catherine Costanza, and I'm a program principal at the National Conference of State Legislatures, and today I'm going to be providing you with an overview of Medicaid delivery systems. Luckily, slightly less complicated than our prior topic. And I do cover Medicaid, but I cover everything except for prescription drugs. So for all questions about prescription drug policy, please don't come to me. In addition to talking about an overview of Medicaid delivery systems, I'll also be talking about state experiences with different Medicaid delivery systems and with delivery system transitions and some of the evidence we have. So before we dig in, I want to just briefly say who we are as the National Conference of State Legislatures. I know I see some familiar faces here from our meetings, but for those who don't know, we are your nonpartisan and bipartisan professional membership organization. And so we represent the over 7,000 state legislators and over 30,000 legislative staff in all 50 states, District of Columbia, and the territories. And we provide all of the services that we've included on this slide, including networking opportunities, trainings, meetings, including health policy specific meetings, and trusted nonpartisan policy research and analysis, including technical assistance presentations like this one and individualized research requests. So if you do have any follow-up questions after this presentation, please feel free to reach out to me afterwards. My contact information is on the end slide, and that's what we're here to do, is to help you. So as I mentioned today, I'm going to cover just an introduction and national overview of the different types of Medicaid delivery systems and kind of what we're talking about when we're talking about what a Medicaid delivery system is. A detailed discussion of the evidence around delivery systems, some of it, and state experiences with different delivery systems, and then a very brief discussion on some policy considerations when you're considering transitioning types of delivery systems or just making big changes within delivery systems themselves. So let's dig right in, and before we do, let's do a quick level set on what I mean when I say the word or phrase delivery system, which you're going to hear about 1 million times in this presentation. So a Medicaid delivery system is how the Medicaid program is structured, who is responsible for certain program operations, and how payments flow through that system. So we're going to come back to that, how it's structured, who is responsible for operations, and how payments flow through the system. And the options here are broadly, we have 2 categories. We have state-operated, which is sometimes called fee-for-service, but I think that's a little bit of a misnomer. It's not always fee-for-service, but it's state-operated, and we have managed care. And the primary difference between these 2 systems is whether or not the state maintains control and responsibility for administering the day-to-day program operations, or whether the state delegates some or all of its responsibilities to a private commercial insurer. And the type, so Obviously, in state operated, the state agency controls or sometimes contracts out with vendors for some of the, to manage cost, quality, and access, program operations, and provider and beneficiary stakeholder relationships, and program integrity. Whereas in managed care, the state agency is contracting with that private commercial insurer and may be delegating some or all responsibility for cost, quality, and access, some of the program operations like provider enrollments, beneficiary and provider stakeholder relationships, and program integrity. And the types of the delivery system also change the role of the state Medicaid agency itself. So different delivery systems require different skills and competencies for the state Medicaid agency to effectively evaluate and oversee the program. And that can also have, as we've talked about today, downstream impacts on how the legislature receives information and what information is available to the legislature. Additionally, it's important to keep in mind that both of these types of delivery systems, state-operated and managed care, use some of the same tools to manage the program, including utilization management tools like prior authorization, choosing to cover some benefits but not others, and the benefits that are covered in different delivery systems, and whether the delivery system holds providers financially accountable for the quality of care provided. And regardless of the delivery system, the state legislative role, which is over the top of this here, remains the same. The state sets standards for the program, state legislature sets standards, it funds the program, and it oversees the program. There are also some differences. And within those broad categories of state-operated on the one hand and managed care on the other, we have 4 primary types of delivery systems. And again, we're going to go back to how is the program structured, who is responsible, and how do payments flow through the program. And we're going to walk through each of these 4 here. So starting on the 4 left with that light yellow column, we have state-operated or fee-for-service, and I'll refer to that as fee-for-service. And in the structure, as we talked about, the state administers the program and manages day-to-day operations. Providers bill the state directly, or sometimes the state will contract with a vendor and providers will bill that state vendor. The state sets payment rates and is responsible for paying providers. And when it relates to providers, the state also enrolls providers directly into the program and must accept any willing provider that otherwise meets the state's requirements. And when it comes to beneficiaries, the state determines beneficiary eligibility and enrolls beneficiaries directly, or again, sometimes through contracted vendors. Primary care case management, which is our next delivery system in column over, which is, you'll see referred to in acronyms as PCCM on these slides. The structure is almost identical to fee-for-service and state-operated. So in this case, it is very similar, but in addition to that, the beneficiary is also assigned a primary care provider that is responsible for coordinating care for that beneficiary. And the payments are essentially the same. Providers bill the state pays the providers, but additionally, the state also pays that primary care provider an administrative fee plus whatever their regular payments are for services. But otherwise, providers enroll in the program in the same way, and the beneficiaries interact with the program in the same way and have their eligibility and enrollment determined in the same way. The next bucket over is our big category of managed care. This is what we think of when we think of Medicaid managed care, which is comprehensive, risk-based managed care. And this is where the structure starts changing pretty significantly. So in this structure, the state contracts with a private commercial payer, as you've heard about. The state will pay that managed care organization a per member per month fee for each beneficiary. Those rates are set, they are required by federal law to be actuarially sound. And the managed care organization is at risk for the cost of services, which you've heard from the speakers earlier today. Additionally, providers, and as you've heard, providers and managed care organizations set rates in the negotiated contracts between them. And providers are billing the managed care organization themselves. So they're not billing the state anymore, they're billing managed care organizations. And the managed care organizations are responsible for paying providers. And both the state and the managed care organization enroll providers. So the state provides the first level of enrollment, which is basically required for fraud and abuse screening to make sure that you have providers that are not otherwise excluded from federal programs or who are not a risk of fraud, waste, and abuse. And then the managed care organization separately credentials the providers that are going to be included in their network. So there is an additional step there. And as you heard earlier, the managed care organizations can limit the providers in their network. And both the state and managed care organizations play a role in enrolling beneficiaries, although as you heard, sometimes there's auto enrollment. There's a couple different ways that states can do that as well. So that's the big kahuna, and then on the very far right here in the blue, we have limited benefit plans, which are a subset of managed care organization plans. And in these, the managed care organization, it operates very similarly to comprehensive risk-based care with some differences. The first difference is that it manages only a subset of benefits. It does not manage a comprehensive list of benefits. It just may cover behavioral health, or non-emergency transportation, or dental, or sometimes manage long-term services and supports. The payment may be at risk or not in a limited benefit plan, depending on whether coverage for inpatient services is included. But otherwise, the provider payment and enrollment process is very similar to managed care, and the relationship with beneficiaries is also very similar to managed care. And you saw a version of this slide earlier. So currently 5 states and 4 territories have state-operated fee-for-service programs. 6 states operate a pure primary care case management system, and 41 states in the territory of Puerto Rico contract with managed care organizations. In 2024, I also want to flag the number of states with managed care is going to increase to 42 when Oklahoma transitions from primary care case management to managed care. We're going to talk a little bit about the history of the delivery systems in Oklahoma a little bit later in our state section.
Madam Chair, could you just repeat those numbers, because our black and white copy doesn't allow us to actually see the numbers?
Yeah, okay, sure.
Of course.
Did you hear that? Yeah.
Absolutely. So it's 5 states and 4 territories have fee-for-service. 6 states operate a pure primary care case management system. And 41 states and Puerto Rico have managed care. And it'll increase to 42.
Thank you.
You're very welcome. I also want to flag, even though I know I just repeated those numbers, that those numbers are a really high-level summary of the big picture here. Most states have a mix of delivery systems, so just calling a state a managed care state or a fee-for-service state may not be accurate. And they have a mix of different delivery systems that serve different populations, and we're going to talk about this in a lot more detail with the few state examples that I have listed. And before we move into state examples, I also want to flag that states often integrate value-based care and payment reforms into the state Medicaid program, regardless of whether the state uses a state-operated fee-for-service, primary care case management, or managed care delivery system. And value-based care refers to a very wide range of healthcare payment and delivery models in which healthcare payers and providers are organized and paid in a way that incentivizes them to focus on providing high-quality, patient-centered care. And it can include a variety of initiatives, such as paying providers based on quality, costs, and outcomes, changing how healthcare providers are organized and incentivized to coordinate care across settings. It can also include strategies to collect, analyze, and manage data to track the costs, quality, and utilization of care or coordination of care. Or it can include measures to establish quality and cost metrics or benchmarks for research and comparison. I also just want to point out that survey data from the KFF Annual Survey of Medicaid Directors from the past 2 years indicates that at least 41 states have implemented at least one value-based care initiative in the state Medicaid program. I suspect it's all 50, I'll be honest. And more than 1/3 of responding states reported a delivery system improvement or value-based payment initiative as a key priority in state fiscal years 2023 and 2024. So these are pretty highly integrated into your state Medicaid programs across states, and they make a difference. Another component here is that states can integrate value-based purchasing in their managed care in their managed care delivery systems. And they can do this by integrating quality measures into the managed care quality review process, and through this, tying certain contractual penalties to failures to meet quality metrics. Some states have tied liquidated damages clauses in their contracts to quality measures. They can also include capitation withholds and incentive payments in the MCO payment and rate structure, where MCOs are eligible for incentive payments for meeting certain quality or performance measures. And states can also incorporate value-based payment targets by requiring managed care organizations to make a percentage of provider payments through these value-based care payment models, where providers are held accountable for quality and access. Because otherwise, the state may hold the managed care organization accountable for quality, but if they're continuing to pay providers fee for service, that may not be flowing downstream. That's the theory behind the policy. Okay, so now we have a lay of the land of the choices for state Medicaid delivery systems, and we're going to dig into the weeds and take a closer look at how all of these things actually come together in the states and what that looks like in certain states. We're going to cover 4 states in this section in detail, and I apologize for how kind of busy these slides look, but this is for your kind of information and perusal later. And we're gonna discuss the structure of their delivery system, which value-based care initiatives have been implemented in the state, and then if that information is available, the outcome of any delivery system transitions and evidence around that. But before we do, it's so important to keep in mind that when you've seen one Medicaid program, you have seen one Medicaid program. When it comes to evaluating the evidence on how delivery system changes impact state outcomes, this is really important because the differences between states are so significant that it can be difficult to both conduct robust research and evaluation and then apply those findings to other states and programs. And I think you heard this a little bit from the first presenter. Every state Medicaid delivery system may cover different benefits or may cover different populations that have more or less complex healthcare needs. They may have different reimbursement rates for providers or services or implement different value-based care strategies. And all of those factors impact cost, quality, and access when it comes to your Medicaid program. The takeaway here is that comparing state delivery systems is like comparing apples to oranges or melons or rocks, frankly. It can be very different when you're looking at these systems. And they're such big systems that there are just a lot of confounding variables to account for. So when we're looking at the evidence, I know this is a lot of caveating before I get into some of the evidence, but what we're really trying to look at is, are we measuring apples to apples across the Medicaid program and trying our best to control for some of those variables, and it's just really hard to do. So, as you heard earlier, and I won't belabor this, the evidence on the performance of different Medicaid delivery systems is mixed, and most of the literature focuses on the outcomes associated with transitioning to managed care, and you heard about that from the first presenter today. I wanted to focus on some state-specific studies that have found improvements to cost or quality associated with transition to each different type of delivery system, but it's different to compare or generalize these results across states and different models. I also want to point out that many studies are not peer-reviewed research, but are also evaluations conducted either on behalf of the state agency or on behalf of Medicaid managed care health plans in the state, which can make it difficult to validate findings across studies. But we do have some studies that actively compare the performance of different Medicaid delivery systems in different states. And of the few that NCSL is aware of, the results are pretty mixed, but I've listed them here. So the first is a 2017 study that evaluated whether the primary care case management or managed care model was more effective at providing care coordination for children when compared to fee-for-service. So again, we're looking at a very specific measure, care coordination for children, across these models. And this study suggested that primary care case management was more effective at coordinating care for children. This one study. A 2021 Health Management Associates Association report found, was analyzing key quality indicators from the Medicaid child and adult core set measures across all three delivery systems: managed care, fee-for-service, and primary care case management. And this study suggested that managed care outperforms both primary care case management and fee-for-service models on key performance indicators related to preventative care, behavioral health, and women's health care. However, in the study, the authors attributed managed care organizations' success to the adoption of strategies like structured care coordination, programs to address social drivers of health, and managed care incentive payments that are tied to key quality indicators. And I just want to point these out because some of these attributes, like care coordination and policies to address social drivers, are not unique to managed care either. They can be integrated into a lot of different delivery systems. The 2009 Missouri comparative analysis was actually comparing the performance within Missouri's Medicaid program, which was split at the time almost half and half between fee-for-service and managed care. And this study did not observe any significant difference in access to or quality of care between delivery systems. Although it did note that the fee-for-service system performed better on well child screenings and prenatal care, while managed care performed better on birth outcomes and provider access. So, but not substantially better in either case. And finally, we do have a 2017 analysis which compared the outcomes of delivery system transitions in both Oregon and Colorado, which are two of the other states we're discussing today. And this study noted that 2 years into implementation, and I'll say Oregon has a managed care model and Colorado has a primary care case management model. And the study noted that 2 years into implementation, Oregon and Colorado's programs both exhibited similar performance on standardized expenditures. Oregon's model was associated with improvements in 3 out of 4 access measures based using the Healthcare Effectiveness Data Information Set, or HEDIS measures, specifically in reductions in avoidable ED visits. But it also noted that Colorado performed as well or better than Oregon in reducing inpatient care days. So, and at the same time, both states experienced decreases in primary care utilization, which the authors speculated could have been attributed to Medicaid expansion and other related increases in Medicaid enrollment in both states. So, as you can see here, we have really a mixed bag when you're looking at, well, what is the best delivery system? We don't know. That's kind of the takeaway here is there isn't a solid answer on what is best. But we do have some evidence around, and we'll kind of dig into the weeds on these different states for what the outcomes have been for them individually when they have transitioned within the state. So now we'll dig into Oregon a little bit more. So Oregon is identified as a managed care organization state where it has about 91% of its population in managed care and about 8.5% of its population in fee-for-service. Oregon has also implemented a huge number of value-based care and really gone all in on a lot of value-based care initiatives, including accountable care organizations, which you heard about a little bit earlier from Dr. Blewett, and primary care payment reform, patient-centered medical homes, global budgets, which I'll talk about just a little bit, value-based payment targets and incentives for these managed care organizations, and they also have an all-payer claims database, so they do have insight into all the claims that are coming through not only their state Medicaid program, but from some other payers within the state as well, to be able to compare costs and quality and utilization across payers. Now, Oregon's system is somewhat unique because it uses entities called coordinated care organizations, which are a hybrid blend of accountable care organizations and managed care. So every individual, every beneficiary that is enrolled in these organizations is counted as a managed care beneficiary. So the CCO, these organization financing is very close to a Medicaid managed care organization than a traditional ACO. In particular, it includes an administrative layer that accepts payment from the state, manages claims, pays providers, and carries the financial risk. These organizations and kind of that accountable care type aspect are made up of a network of all types of healthcare providers that include medical, behavioral, and substance use providers, and they're focused on prevention and helping people manage chronic conditions. These CCOs have one global budget that grows at a fixed rate and includes coverage for all mental, physical, and dental care. It also includes accountability measures for the health outcomes of the population that is attributed to that that CCO. And they're also governed by a partnership among healthcare providers, community members, and stakeholders in the community. And today there are 16 different coordinated care organizations operating around Oregon. And for the most part, each CCO is responsible for a different geographic region. And the beneficiaries within the region are automatically assigned to the appropriate CCO. So that's a lot. So I'm sorry that the links aren't showing up as clearly on this slide, but I have all this information linked in the slide if you want to check it out. So Oregon made this transition to this kind of hybrid ACO-MCO model in 2012, along with comprehensive Medicaid reform and their Medicaid expansion. And as a part of this, they did this with a pretty significant federal investment that's distinct from the normal cost sharing between the federal and state government. So it was about a $1.9 billion federal investment for Oregon to make this full transition to collaborative or coordinated care organizations. A couple studies have found that Oregon experienced a 7% relative reduction in expenditures and reductions in emergency department visits as a result of this transition. They also noted that they reduced disparities in primary care visits and access to care, but not necessarily in ED use, and this was specific to the Black community and to American Indian and Alaska Native enrollees in the program. As we discussed earlier, they had pretty comparable outcomes to Colorado in that study we discussed, and they also noted that they had lower cost growth than Washington, which has a managed care organization model, but had a decline in primary care visits. So overall, some positive outcomes, pretty significant investment. All right, Colorado. So Colorado has a primary care case management predominant model with about 11% of the population in managed care. And that's limited just to the county of Denver and I think around their safety net system. I actually don't have a lot of information around kind of that little pocket of managed care in Colorado. And they don't use any limited benefit plans either. And Colorado has also implemented a fair number of value-based care initiatives, including accountable care organizations, primary care payment reform, patient-centered medical homes, bundled payments, and they also have an all-payer claims database. Colorado also uses accountable care organizations, which in the state are called regional accountable entities, or RAEs. And under these RAEs, a regional organization receives a capitated per member per month fee specifically for care coordination and certain medical home services, while the remainder of medical services are paid to the RAE on a fee-for-service basis. And the state also integrated behavioral health into its accountable care organizations in 2018. So Colorado transitioned to a primary care case management model following a lawsuit, increasing costs and budget uncertainty associated with their managed care delivery system. And as I mentioned, they integrated behavioral health into accountable care organizations in 2018. And as reported in a 2017 analysis conducted by the Colorado Health Institute, which is a nonprofit, nonpartisan research and consulting group in the state, a University of Colorado study found that the accountable care collaboratives both maintained quality and yielded savings up to $900 per enrollee per year after 4 years. I do want to flag here that even though this University of Colorado study was cited in this analysis, we haven't been able to identify the underlying or find a public version of the underlying study, so there may be some caveats that we're not addressing about that study, okay? The same study that we also discussed earlier found that Colorado had comparable cost outcomes and better outcomes on the reduction of inpatient hospital visits when compared to Oregon, but Oregon performed better on certain measures of access. Okay. And we'll transition on to Oklahoma. So As of right now, although this is going to change, Oklahoma is primarily a primary care case management delivery system, with 66% of its population in primary care case management, 34% in fee-for-service, and they also have a limited benefit plan for transportation benefits. And they also have some value-based care initiatives, mostly centered around patient-centered medical homes and some primary care payment reform initiatives. And as I mentioned, Oklahoma is intending to move from primary care case management to a managed care model in 2024, although they are keeping patient-centered medical homes and some of their primary care payment reforms. Additionally, I want to point out that Oklahoma has integrated behavioral health in its delivery system since 2004 and has increasingly focused on those primary care payment reforms and integrating those into the Medicaid program. For example, Oklahoma's model includes an expanded performance-based component, which rewards providers for meeting certain metrics for childhood screenings, cervical and breast cancer screenings, and emergency room utilization targets. And they integrate primary and behavioral health care into their patient-centered medical homes. So as part of the future state, Oklahoma passed legislation requiring the state to move back to a comprehensive managed care model. And the state Medicaid agency is required to award at least 3 Medicaid managed care contracts to health plans or to provider-led entities, which are similar to accountable care organizations. Interestingly, provider-led entities would receive preferential treatment in the bidding process, with at least one targeted to receive a contract. But if no provider-led entity submits a response, the state's not required to contract with one. And Oklahoma will award contracts to provide integrated medical, behavioral, and pharmacy coverage to certain eligible populations, and the eligible populations will include children, pregnant women, newborns, parents and caretaker relatives, and the expansion population. So Oklahoma is interesting because we're going to focus more on their transition originally from managed care into primary care case management before their kind of future transition back. Back to managed care. So Oklahoma transitioned from managed care to primary care case management in 2004 due to increased budget pressures and a lack of provider participation in the managed care organizations. And as I mentioned, the primary care case management model integrated acute care, primary care, specialty care, and behavioral health services on a fee-for-service basis, but their primary care providers were paid a fixed per member per month fee for primary care services and for care coordination services. So very much in line with that primary care case management model and that patient-centered medical home model. And an evaluation conducted by Mathematica in 2009 of the transition to the primary care case management model found that the transition was associated with a decrease in emergency room utilization and preventable hospitalizations for adults. Additionally, costs per member were substantially below national averages, although that was between 1996 and 2005, and so that time period may have included still the performance of Oklahoma's managed care organization before. Additionally, 7 out of 10 respondents reported no problem seeing behavioral health providers, and so it seemed like access to behavioral health care was maintained. And last but not least, this is our last state example. I know these are pretty dense. We'll talk about Connecticut. So Connecticut is one of the rare states that does have like 100% delivery system. They have 100% of their beneficiaries in fee-for-service and no limited benefit plans. They also have patient-centered medical homes and an all-payer claims database. But the Connecticut Medicaid program is unique in its structure. It's a fee-for-service delivery system, but it operates like a self-insured employer program, and it has administrative functions that are managed through an administrative services organization. And they refer to this as managed fee-for-service. And the Connecticut model also provides comprehensive coverage of preventative medical, behavioral health, and dental services, and includes care coordination and care integration as well. So Connecticut transitioned from managed care to fee-for-service in 2012 into that kind of administrative services organization managed fee-for-service model. And evaluations in 2019 and 2021 found that costs, and these evaluations were conducted by the nonprofit, nonpartisan consumer advocacy organization, Connecticut Health Policy Project. And these found that the state costs decreased between 2012 to 2018, resulting in estimated savings of $968 million. And estimates of the state's administrative costs range from 2.8% to 4.2%, depending on how you're calculating it, but they generally fall below national averages. In a later 2019 in the 2019 evaluation, the state estimated that that per member per month costs decreased from $706 in 2012 to $610 in 2018. And we're almost done. We're just going to briefly talk about some policy considerations when evaluating changes within and to the Medicaid delivery systems. And the biggest point here is that delivery system transitions or big changes, they're monumental efforts for your state Medicaid agency. And they're generational investments often. As you can see from some of the examples here, we're talking about delivery system changes that happened between 2004 to 2024, happened in 2011 or 2012. We're talking more than 10 years in, okay? So there are a lot of policy considerations to keep in mind when thinking about these transitions or big investments, including your timing. How is that going to impact your Medicaid agency staffing, vendor contracting, and implementation? Are there impact to ongoing projects and priorities? I'm sure your Medicaid agency is going to tell you they have a lot of priorities, not the least of which is unwinding right now, as well as lots of other state and federal upcoming deadlines. So how are those changes going to integrate into those other priorities? If you're changing delivery systems especially, are there new agency functions or competencies that your agency is going to need to perform? Does that come with staffing and systems updates? And with that comes a budget impact. If you need staffings, operations, system updates, what are the costs of those transitions? And then of course, and like definitely not least, there's the communication with all your stakeholders, your beneficiaries, your providers, the agency, and the managed care organizations themselves. And with that, I also just want to briefly point out, we do have a whole series on both value-based care and Medicaid managed care, including the life cycle of oversight. We're about to publish a publication on quality review process in managed care, so please feel free to check out the linked brief series in here as well. We have plenty of resources on this topic.
Well, thank you so much. I know you visit legislators around the country, and you're kind of the point person for these kinds of questions for legislators. And from my observation from going to NCSL meetings with other chairs of the healthcare committees and so on, I think all of us are wrestling with these same issues in one form or another, right? Because these are really important for our states and really important parts of our budgets. And so we all want all of these things to come together in the right way. And so really appreciate your being here. I know she came from Denver to be here with us today. And I know that she, early in the slides, gave some links and so on. And I've looked at the materials on the website. They're very good. And so I really recommend that to everybody, and to use NCSL as a resource for these questions. So thank you so very much.
Thank you, Madam Chair.
I see one question from Representative Elkins.
Thank you. Ms. Costanza, it almost, you look at these case studies and it almost looks like there's a Hawthorne effect thing going on here. It's like no matter what type of system you switch to or from, you see an improvement.
I don't know that I could say that across every single study. I don't know that I've looked at every single state transition, so I couldn't say that definitively. But in some of the literature that I have seen, I agree. It does seem like states are looking to transition when they're looking to improve something.
Yeah.
Sorry, Madam Chair
Yeah.
and Representative
No.
Elkins, I apologize.
Representative Elkins, anything further? Representative New Brindley.
Thank you, Madam Chair, and thank you, Ms. Costanza.
Yes.
Excellent. And actually, I think my question might be for Mr. Burke again. And it goes back to the slide on Medicaid delivery systems, value-based purchasing, and MCO delivery systems. We know that part of that are these capitation withholds and the incentive payments, and I'm wondering if you know how much money that is. Do you know, like, in total, what those withholds are?
For Minnesota, I don't off the top of my head. We do have a withhold. And I can't tell you off the top of my head, but I could get back to you.
That would be great, thank you. Thank you, Madam Chair.
And Madam Chair
Ms.
and
Costanza.
Representative New Brindley, I can at least say this will also be covered in our publication coming out in the next couple days or so on quality review and value-based purchasing. We do have some state examples. Some of the percentages that I've seen across states range anywhere from 1% to 7%, depending on the state. It's usually in the range of 1 to 3. But it, at least from what I've seen so far, but it depends on the state. And it's usually a withhold and then from the capitation payment up front, and then the incentive payments are paid back when they meet certain quality measures. Yes.
Thank you.
Yeah, okay, Representative Quam and then Fisher.
Thank you, Madam Chair. On the previous comment, you had in your slides, one of the states moved from MCO to another and then is moving back to MCO. So that sort of counters the thing that once you move, it's better. But the other thing, I'm curious because we heard that 49% of Minnesota's Medicaid dollars go to MCOs, but those MCOs cover 85% of the people. Outside of these programs, whether it's MCO or et cetera, what are the other things that the dollars are going to?
Madam Chair and Representative, would you mind clarifying kind of the dollars to who? Are you saying the dollars to the managed care organizations or the dollars within the agency?
Representative Quam.
Thank you, Madam Chair. Because in the data presented today, 49% of Minnesota's Medicaid dollars go to MCOs, but also in the data that 85% of the people are using MCOs instead of the fee-for-service. So that if 15% is not MCO, why is 51% of the costs outside of the dollars going to the MCO? So therefore, I want to know where the other big consumer of thing, and you've got all these other states that you've looked at, so you understand that
Population.
these are the things you do, but there's an overhead or there's some additional place these dollars are going.
Madam
Ms.
Chair.
Costanza.
Yeah, Madam Chair and Representative. I'm so sorry, I can't see your name.
Quam.
Is it Quam? Okay, thank you, sir. That's an excellent question. So Minnesota is actually pretty consistent nationally with what we see in terms of the national figures around Medicaid managed care spend versus managed care enrollment. So nationally, all states in aggregate are spending about 54% of their budgets on managed care, but it's covering, I think, about 72%, sometimes up to 80%. But this gets at what the first presenter spoke about today, which is who is covered in managed care. So over 80% of children are covered in managed care, and adults in the expansion population are covered in managed care. Whereas adults with disabilities and just people with disabilities generally, as well as older adults, are more likely to be covered in fee-for-service. And those populations account for a disproportionate share of spending because they have more complex healthcare needs. Children and adults in the expansion population historically have the lowest per member per month or per enrollee costs in the program. So when you look at kind of that discrepancy between, okay, fee-for-service only accounts for 15% of the population, but it accounts for 50% of the spend, at least in Minnesota. Again, that tracks nationally. When we look at national enrollment and spending figures, approximately, I might get some of the figures a little off here, but approximately 20% of the enrollment is for people with disabilities and older adults, but they account for about 50% of the spend. So that's about on par.
Yeah, thank you. And I think I also recall the fact that the nursing home spending is also Medicaid spending, but it's also not through MCO, so that's a huge chunk, right? Yeah.
Yes, and Madam Chair and Representative Quam, to follow up on that, long-term, people who predominantly use long-term services and supports are those which include nursing facilities and the whole spectrum of home and community-based care and nursing facility care is overall more expensive than some of the other services we see in the program, but those are predominantly used by people with disabilities and older adults. So again, we see services that align with the higher health needs of the population.
Okay. Representative Fisher and then her.
Thank you, Madam Chair, and thank you, Ms. Costanza, for being here today to help give clarity or information to us as to what works and how other states are doing it. One of the questions that I had is going to the managed care organizations overall. In our state here, we've got a number of them that are county-based, where the counties are running it. Has there been much exploration or research as to how that looks across the country as to programs, MCOs that are run by counties versus those that are run by insurance companies? If there's any significant differences in terms of not only outcomes, but also in terms of the types of different services that they provide?
Ms. Costanza.
Madam Chair and Representative Fisher. I'll be honest, the county-based purchasing, this is the first time I've heard of it today. So I'm not aware of anything. I think if you're asking about geographic distribution of managed care organizations and how states, whether they contract statewide with a few managed care organizations, or if they contract regionally with certain managed care organizations, or if they have competitive processes. I do have information on that, but I am just not aware of any information that specifically compares kind of a county-based model versus a regular MCO. Although, as I'm saying this, I feel like a neuron is firing around California might have some similar county-based purchasing, but I can look into that and follow up with you if that's accurate or if I'm just imagining something else.
Representative Fisher.
Thank you, Madam Chair, and thanks, Ms. Costanza. Yes, if additional information, that'd be great. And then also getting a feel is, because one of the things that really intrigued me about the county-based system is the fact it's what I'm used to calling as wraparound services, is that they're doing more work along, what are we doing to address the homelessness, the food insecurity, et cetera, which typically doesn't have payoffs in the near term, but takes several years before you see that. And the reason I'm asking the question, because I would think that insurance companies are not guaranteed they're going to have that same person, say, 1 or 2 years down the road when that benefit comes in, and may be less likely to invest in those kind of programs versus a county-based program where they will have these people that they're serving for generations potentially.
Yeah, very good. Representative Her.
Thank you, Madam Chair. And I think that maybe I just have more of a comment. One, I just wanted to say thank you for holding this, because there was many things that was presented today that I needed to hear and I needed to see as a first-time health committee member. So I just wanted to say thank you for doing that and not sort of rushing it while we were all in session, in a shortened session this year. I wanted to also say thank you to my Republican colleagues, because I felt like your questions were really thoughtful. And I think that what I got out of today was that we all really care, regardless of party, about who is served under Medicaid and ensuring that it works for everybody. And that's so reassuring to me, and I really appreciate that. And that we all really care about transparency and being good steward of public dollars, regardless of which side of the aisle that we're on. And also that we care about diving in to look at the different pieces that make up this system, and that we're all in agreement that we don't pull a lever without looking at the totality of what it is we're trying to do. And I felt that really, even though sometimes we were sort of going back, I really felt that we were all really unified and really understanding that. And I really appreciate your leadership and all this, Chair Liebling. And I wanted to just loop back, because I'm really sorry that I missed the 340B piece of it, so I'll go back and rewatch that. But I did just want to maybe in the future about the presenters and what we're doing is that, there were sometimes some people just presented very factual things about, and then sometimes people provided their opinion. And I think opinion is always important, but I think for us to also be really careful about when we're hearing what is being presented to really think, because I'll just point out one particular thing, and this is not a criticism of an individual or of anybody in particular. I'm not advocating for one thing or another, but I just want to point out that when there was a comment made that nonprofits and for-profits are kind of the same and they make the same decision, so it really doesn't matter the structure. But I just want to be really clear that who benefits from that structure at the end matters, whether you have shareholders or whether you are serving the public. And that when you look at a UHC CEO who makes $2.9 million versus a health partner CEO who makes $2.4 million, and the size of their assets of $494 billion, net worth of $494 billion versus one that has, $613 million, that, and profits are just, they're not comparable. And what drives why somebody chooses to do something, the outcome might look the same, but the motivation is very different. And so for us to just be really conscious about how do we pair the public good that we're trying to do with the financial balance of also ensuring that we understand the structures that we're making these decisions in. And so I just wanted to kind of make sure that that was put out there, because I think sometimes we think opinion and fact might be similar. And so I just, I just wanted to throw that out there. I have a lot more I have to go back and look at, but I just wanted to really ultimately point out, I really appreciate your leadership in this, Chair Liebling, and everybody's willingness to actually see that there's a lot more common ground between what we all think on both sides of the aisle and what we want to do with this. So thank you.
All right, thank you. Representative New Brindley.
Thank you, Madam Chair, and thank you for the, for the latitude. And let me ask again, I had notes and I didn't even address this question, but I'm wondering, Ms. Costanza, if you can address, I'd be interested to hear a little bit more about Connecticut, actually. I'm afraid I didn't totally catch as you were talking how this functions, but can you talk about how the fee-for-service is administered? And sort of secondarily, clearly the majority of states that do fee-for-service, I think at least 4 of the states that do fee-for-service are in the lowest 10 population states. They're small states, and Connecticut's a little more than half the size of Minnesota. They're smaller states. Can you talk about how population might affect the administration of that as well? And just again, specifically, I didn't totally catch how Connecticut is administered.
Yes, Madam Chair and
Costanza.
Representative New Brindley. I can give you the high levels. If you'd like more detailed information, we're more than happy to put you in contact with Connecticut's Medicaid agency, since obviously their agency is going to, I think, have the most details on that. But it is so many states contract with vendors to do specific components of their program operations. For instance, claims processing, provider enrollment. There's usually several vendors that are involved in kind of helping perform those administrative functions. My understanding is that the way that Connecticut's Medicaid program is slightly different is that they have all of those administrative functions that are performed through a single administrative services organization that manages the those components of the administrative services, beneficiary eligibility determinations and enrollment, provider claims processing, provider enrollment, and some of those just day-to-day program operations so that they can keep an eye on some of the other components of it. I am not as in the weeds on exactly how that operates or how that's structured and divided out, but again, happy to provide more specific contact information with Connecticut if that's requested by the committee. And then I'm so sorry if I'm blanking. What was the second question?
Representative New Brindley.
Thank you, Madam Chair. Actually, it might be very much, I'll clarify the second question with what you just said. So the single administrative services organization that provides these functions for Connecticut, presumably that is not the state. That's an outside vendor that they're working with. And so secondarily then, with these other sort of smaller states, are they, do they perform those functions in-house, or do they also use an external vendor for those functions? It seems like there's clearly at least a correlation between the size of the state and the ability to manage these functions.
Ms. Costanza.
Thank you, Madam Chair and Representative New Brindley. Thank you for the reminder on the population component. I can't say specifically whether or not these other states that have fee-for-service, the extent to which they use vendors for different functions. I can look it up for some of it, and so I'm happy to kind of follow up and see kind of how they change it out. I'm also not sure, again, quite how Connecticut structures that contractual relationship with their administrative services organization, so would need to connect you with somebody more knowledgeable on that front. As it relates to the population and kind of what we see between delivery systems, I think one of our speakers earlier today did mention that Smaller states with lower populations are not as quick or have not been as quick to enroll in managed care. I don't know quite what the reasoning behind that is, but managed care really took off when there were changes in federal regulations that permitted states to allow statewide automatic enrollment in managed care organizations rather than providing patients with choice. And the reason for that is because it provided those economies of scale, essentially. There were enough beneficiaries enrolled in the managed care organizations to make it a viable model, essentially a viable business model for those states. And that I think also contributes to, helped contribute to increasing provider enrollment in the MCOs as well, at least that's my understanding.
Thank you, Madam Chair.
Thank you. So just to kind of in closing here, I just wanted to, Ms. Costanza, thank you again. And something you said triggered my brain, and that is we have this county-administered system also. Our counties do our enrollment. And that might be really different than the way a lot of other states do it, no? No, okay, okay.
I know at least Colorado uses county-based enrollment. I believe New York uses county-based enrollment, and maybe California. I would need to double check, but several states do use county-based human services enrollment systems overall.
Okay, and then just kind of going back to one of your early slides, where you had it sort of in two buckets. You have state-operated / fee-for-service versus managed care. And from what I got from your presentation is maybe another way of thinking of that is really public-operated, or maybe it has to do with this thing about taking financial risk, which was mentioned earlier in our presentations, but we didn't really unpack that, and I probably would have liked to. I didn't really think about it at the time, but that's a big issue. What does it mean to shift the financial risk and that whole predictability thing that people talk about? Because personally, as a fiscal chair, I don't know what that predictability, financial predictability thing means. I never experienced that. Like, where's the predictability for us on our budget sheet? I just don't really see that, okay? It doesn't mean anything for me as a decision maker. So that's kind of an aside. But when I look at your sheet here, I think maybe what this really is where the public is keeping all of the risk, but still hiring vendors, still working through private provider systems, still doing all kinds of perhaps different things to get quality. It doesn't preclude any of those things. And then on what you have managed care is really shifting it to private entities who then perform these functions, including the financial risk. Is that kind of what, because as I'm hearing what all the different states do, it really occurs to me that the same tools are there available across the spectrum, the value-based purchasing, the sort of the ACO thing that we talked about. All these different tools are available and used in different ways. And this top line thing, is it an MCO or is it a PCCM? Those are kind of such vague terms when you really unpack what's going on that it doesn't mean all that much really. So I think the real distinction is, does the state keep the risk and manage it and do more of the nitty-gritty management, or do we outsource that, hire somebody to do that for us? Does that make sense?
Madam Chair, yes, I think I understand what you're getting at here. And I also want to touch briefly on what you mentioned about the budget predictability. I defer to some of my academic colleagues and speakers who spoke earlier if they're aware, but I'm only aware of one study that has actually evaluated whether managed care brings budget predictability. And the conclusion of that study was that it doesn't necessarily, specifically because capitated payment rates fluctuate with enrollment. So if your enrollment increases, your payments to the managed care organization are going to increase, and that may increase on a monthly basis or whenever the state evaluates that. So now, again, one study is one study. That is not a conclusory body of evidence. So please take it with that caution. But I think that is somewhat compelling in some ways. In terms of whether state agencies assume financial risk, I don't necessarily want to push back, but I will say Medicaid spending from the federal government fluctuates with actual expenditures. So at some point, the agency really isn't assuming a lot of risk because the state and the federal government true up the spending at the end of their cost reporting period, which is why expenditures take so long to report out, why we always have like 2 years behind on Medicaid expenditure data. It takes forever to get to that actual expenditures
Right,
report.
I'm not thinking of the agency taking risk. I'm thinking that, the state, whether the state bears the risk or shifts it to MCOs. I mean, that's been part of the pitch. Oh, we're shifting the financial risk. But anyway, I don't want to go into that because it's another hour and we are
And it is
over
a
time.
delegation. I will
So-
say, it is a delegation of responsibility.
Yeah.
I think to your point, the responsibility of those program operations and how the state exercises oversight.
Yeah.
I think the states exercise oversight over managed care through contractual liability, through their quality review processes, which happen every 3 years. State agencies have a lot of tools to exercise oversight, but it looks different when they're exercising oversight over a managed care organization rather than when they're doing it in-house. So I agree that it is a delegation of authority for the day-to-day program operations and some of those responsibilities.
Well, thank you very much for your presentation. Thank you again to all of the presenters, and thank you to the members and the audience. It's been kind of a long day, and one that, I think I know I'll be like going to sleep tonight and processing all of this, because there's an awful lot to process. And so may you dream about MCOs. Sweet dreams. But thank you very much, and with that, we are adjourned.